Good evening, friends, and welcome to the October edition of Glaucoma Australia's live Q&A, which is proudly brought to you by our long-standing and generous supporters at Glaucos. My name is Natasha Sickman, and I'm one of the senior orthoptist patient educators leading Glaucoma Australia and the valuable services that we provide to our communities. Before I introduce you to our guest speaker this evening, I would like to take a moment to acknowledge the traditional custodians of the lands, skies and seas in which we collectively gather for tonight's event, and I pay my respects to elders past and present, along with their emerging leaders. Tonight's live Q&A topic is on minimally invasive glaucoma surgery, or MIGS as they're often referred to, and why it's so important. We are fortunate to have this presented by one of Glaucoma Australia's good friends, Dr. Colin Clement. Dr. Clement is an ophthalmologist based in Sydney who specialises in the management of glaucoma and cataracts. He is a senior clinical lecturer at University of Sydney and an honorary medical officer at Sydney Eye Hospital. His clinical and research interests focus on surgical management of glaucoma, and this is reflected in more than 70 peer-reviewed research papers he has authored, along with book chapters and invited lectures, both here in Australia and abroad. He leads the glaucoma team in a multidisciplinary clinic for patients with corneal blindness and is the course coordinator for minimally invasive glaucoma surgery training at Sydney Eye Hospital. We are privileged to have Dr. Clement with us this evening. Please join me in warmly welcoming Dr. Colin Clement tonight.
Thanks very much, Tash.
Thank you.
Good evening, everybody, and thank you very much for joining me for this discussion on minimally invasive glaucoma surgery. I've framed it in terms of what's relevant in 2024 and why is it so important. I'm going to be focusing on the main MIGS surgery options that are available to us in Australia currently. Now, as I go through this presentation, I'm going to be doing so based on some assumed knowledge. And I know as an audience, you know a lot about glaucoma already. But if anything that I'm not covering is unclear to you, we can put it in the discussion at the end. So I'm going to assume that you know that glaucoma is an optic nerve condition that results in vision loss, typically affects the peripheral vision early on and comes in towards the centre of the vision later in the disease. Eye pressure is the most important risk factor in glaucoma, and that's because it's really the only modifiable risk factor that we can have any meaningful impact on with our treatment. And as such, reducing eye pressure is the main treatment for glaucoma. So with this in mind, it's important to understand what determines eye pressure, because from this we can understand what are the different ways we can control eye pressure. So here we've got a figure of an eye in cross-section, and then we've got a blown up box showing the part of the eye that's involved in pressure regulation. So you can see that all the factors that influence pressure are towards the front of the eye, and nothing really towards the back of the eye influences pressure in normal physiology. So what happens is you've got a structure called the ciliary body, which sits behind the iris. It secretes a fluid into the eye called aqueous. That aqueous flows around the lens. It flows through the pupil into the front segment of the eye called the anterior chamber. And from there it flows out of the eye across a structure called the trabecular meshwork, which looks a bit like fly screen under a microscope, behind which is a channel or a canal called Schlem's canal. That canal collects the fluid and then disperses it through the venous system and back into the bloodstream. So knowing that, it's pretty easy to understand that you can modify eye pressure either by increasing the amount of aqueous that leaves the eye or decreasing the amount of aqueous that comes into the eye. It's simple plumbing, really. Now, most of our treatments are directed towards increasing aqueous outflow, and you can subdivide these into the pathway of increasing the aqueous outflow. So there's the conventional pathway. So that's the pathway I just described to you, where the fluid flows across the trabecular meshwork and into Schlimm's canal. There's a subconjunctival pathway. So that's not normal physiology, but it's a method by which you move aqueous into the subconjunctival space from where it is absorbed back into the bloodstream. Or there's a suprachoroidal pathway. So the suprachoroidal space is a layer between the middle layer of the eye, the choroid, and the superficial layer of the eye, the sclera. And if you can direct fluid into that space, it also gets absorbed and disappears. If we look at the treatments that are currently available, first of all, medications, which most patients take, certainly as initial treatment, they either increase aqueous outflow via the conventional pathway, or they decrease aqueous inflow. So types of medications that increase outflow include the prostaglandins, such as Zaletan, Levagan, Travatan, and anything that's got a combination with those agents in it, or an older medication, pilocarpine. Medications that reduce inflow include timolol, alpha agonists such as Alphagan, and carbonic anhydrase inhibitors such as trusoptanazole. We also have laser treatments. Now, these are sometimes used as first-line treatment or in addition to medications. And a conventional laser is the laser trabeculoplasty. So that's treating the trabecular meshwork to try and open up the pores and allow the aqueous to flow out better. And you also have lasers that decrease inflow. Now, they're typically done in an operating theatre with an anaesthetic, and that's the usual one would be a transscleral cyclodiode treatment. And that tends to be used in later disease. And then beyond the medication, the laser, we've got conventional surgery. Now, conventional surgery has either been trabeculectomy or a glaucoma drainage device, and both of those shunt aqueous into the subconjunctival space, so they're considered subconjunctival procedures. So if you look at all that together, that matrix, that's basically what conventional glaucoma treatment looks like, and you can see from that there's definitely some gaps in terms of ways we can control pressure. There's no medication that increases subconjunctival flow or suprachoroidal flow. There's no lasers that do that, and there was no conventional surgery that utilises the conventional outflow pathway or decreases aqueous inflow. So that's where MIGS has provided us with an opportunity to fill a treatment gap, because MIGS allows us to increase aqueous outflow via the conventional pathway. There are MIGS that increase it via the subconjunctival pathway. There's MIGS that does it by the suprachoroidal pathway, and there's even MIGS that decreases aqueous inflow. Now, what I'm going to do with this presentation is focus on the aqueous outflow, because they're the interventions that are primarily used and readily available in Australia. And I'm going to do that by discussing each procedure or technique in turn, and use some surgical videos to demonstrate that. But before that, let's just define what MIGS is. So as we said at the outset, MIGS stands for minimally or micro-invasive glaucoma surgery. And when it was first becoming available as a clinical tool for treating glaucoma, it was set up with a couple of parameters in place. So first of all, it had to be ab interno, which means that the treatment was done inside the eye, as opposed to operating on the outside of the eye, which is typically the technique used for a traditional trabeculectomy or glaucoma drainage device, or even a transscleral cyclodiode. The second important point was that it had a good safety profile. These treatments were aiming to have a modest intraocular pressure reduction. So we're not looking for huge reductions in pressure, but something that's meaningful and useful to the patient. And another important feature was that the patient recovered very quickly from surgery. Right? So these were the defining features early on. And then if we look at where MIGS fits within what we're doing already, you can think of it in terms of risk versus reward. So if you plot the different groups of treatments on a graph like this, where on the one side, the y-axis, you've got risk and adverse events from treatment. And then on the x-axis, you've got the amount of pressure reduction you can achieve. It looks something like this. So on the one hand, you've got medication and laser trabeculoplasty. They're fairly similar in terms of the amount of pressure reduction you can achieve. They're also similar in terms of their safety profile, but they're not free of risk and complications. Certainly things can occur. And then at the other end, you've got trabeculectomy. So trabeculectomy is brilliant at reducing intraocular pressure, and you can get pressures to very low levels with that type of surgery. But there are potentially significant complications that can occur with that treatment as well. So that's why it's way out to the right and up high. What you can see there is there's a treatment gap. There's a big transition from medication and laser to trabeculectomy. And the reason this is important is because if you look at glaucoma severity as a population, in terms of everyone that has glaucoma, the majority of patients have either mild or moderate disease. So if these are the patients in whom medication doesn't work, or laser doesn't work, or the side effects from medication are intolerable, or they're having trouble using the medications for whatever reason, then progressing on to something like a trabeculectomy is inappropriate because the risk that you're exposing them to is too great versus the severity of the disease. So it's for that reason we needed something that fills that area in the middle, and that's where MIGS has stepped in and added a fourth dimension to the way we approach glaucoma treatment. All right, so what I'd like to do now is go through some of the techniques and devices we're using in 2024. So we break it down into the three mechanisms of outflow. So you've got the transtrabecular MIGS, you've got the subconjunctival MIGS, and the suprachoroidal MIGS. All right, so let's look at the transtrabecular MIGS first of all. There's four techniques available in Australia at the moment. We've got the iStent Infinite, we've got the Hydrus, we've got the iTrack Advance, and we've got something called GATT. Now the iStent Infinite is a heparin-coated titanium stent that's shaped like a rivet. There's actually three of them that come preloaded on an injector, and these are injected into the trabecular meshwork and provide a direct communication between the anterior chamber, where the aqueous is circulating, and Schlemm's canal, which drains the aqueous away. Now, the iStent Infinite is an evolution of the original iStent, which dates back to somewhere around 2014. And there's been a number of evolutions in the design, and it represents the best iStent we've had to date, both in terms of use and response to treatment. The Hydrus is made out of an alloy called nitinol, and it's a scaffolding device. So it's injected into Schlemm's canal. It provides a direct communication between the anterior chamber and Schlemm's canal, and it also holds it open. It's about the size of an eyelash, about 8 millimeters long. So quite a big device in comparison to iStent. The iTrack Advance is a type of treatment called canaloplasty, and what this is a cannula that's inserted into Schlemm's canal, and then a agent called viscoelastic is injected. Now this is like a clear jelly, and what it does is it dilates the canal. And the idea behind it is that you go all the way around the canal and use the viscoelastic to dilate it and open it up. And the concept is that it improves the ability of aqueous to flow circumferentially within the canal. And then GAT is a technique whereby you actually remove the trabecular meshwork completely. So GAT stands for gonioscopy assisted transluminal trabeculotomy. And it basically involves passing a suture through Schlemm's canal through 360 degrees and then pulling it tight until it rips the meshwork out. And we'll show you that shortly. So I've got a couple of videos here for you. April, if you could put the first video on for us. So this is a video showing the insertion of iStent Infinite. So what we've got here is a view of the angle of an eye, and that's the injector going in. And the little spear at the end called a trocar is inserted into the pigmented band where the trabecular meshwork is. The trigger's deployed and then the stent is released, and you can see one sitting there straight ahead in the field of view. You then move to one side a couple of clock hours and repeat the same process. There's the second one. And then usually the surgeon has to reposition slightly so they can get the right angle of approach to get the third one. Now, the reason we put them a couple of clock hours apart is we're trying to access as much of the Schlemm's canal as we can with the aqueous flowing through the stent and away. And studies show that you get a good flow of aqueous at least 1 clock hour either side of the stent. So if you've got 3 stents 2 clock hours apart, then you're accessing about 6 clock hours of Schlemm's canal, which in theory will increase your chance of getting pressure lowering. Okay, April, can you move on to the next video, please? Okay, now this is a video of a hydrus being inserted. So same view of the angle, aiming for the trabecular meshwork, which is pigmented there. The tip of the injector is pierced through the trabecular meshwork into the canal, and then the dial on the injector is rotated forward, which pushes the hydrus implant through Schlemm's canal, like so. And you keep going until the injector releases it, and then that's it. So you have a small segment of the hydrus sitting in the anterior chamber, and the rest of it is sitting in the canal there. Just trying to advance it a little bit further. Great. Next video, please, April. Now, this is a video of canaloplasty, of which eye-track advance is one technique. Now, it's a similar looking injector to the hydrus, but rather than injecting a metal stenting device, you're actually pushing through a cannula which has a light on the end, and the light shows that the cannula is passing through the canal unimpeded. So the surgeon can actually follow that light as it's passing around. Currently they're just going in and out, getting the right plane there. So going around now, and you'll see the light coming around there. Yep, as it keeps passing around the canal, and that will go 360 degrees around until you're back to the beginning. And then what the surgeon does is start to withdraw it slowly, and with each withdrawal, a dial is used to deploy a small amount of the viscoelastic and dilate the canal. And that's done until they all come all the way back to the beginning. Okay, next video, April. And then this is a demonstration by my colleague Zeynep from Turkey on the technique for doing GAT. So this is a suture being passed into Schlemm's canal, and again it's pushed all the way through until the end comes back to the beginning, which you can see coming through now. And then what the surgeon will do is grab that tip like so, and then they grab the other end of the suture and they pull it like a purse string. And what that does is it rips the trabecular meshwork away completely. All right, great. So back to the slide deck. Thanks, April. All right, now let's talk about evidence. In terms of the efficacy and safety of these four techniques that we've discussed, the evidence is strongest for iStent Infinite and Hydrus. Both have been studied in randomized clinical trials with good follow-up, well-controlled and well-designed studies. So the evidence in support of them is very good. And if you compare the outcomes between them, they're both very, very similar. Depending on the report you read, there are slight preferences in outcomes one way versus the other. But if you look at the entire literature as a whole, on average, my reading of the data is that they're about the same. In contrast, iTrack Advance and GAT has much less evidence to support it. In particular, iTrack Advance, there's no randomized clinical studies that have reported outcomes. There's lots of studies from single surgeons, retrospective and prospective, but certainly not the quality of evidence that's available for the iStent and the Hydrus. And one of the problems with iTrack Advance in Australia currently is that there's no reimbursement for it from the government. Now, that's not to say it won't come in the future. I hope it does become available, but currently that's not the case. GAT also doesn't have a large number of studies to support it. There has been one randomized clinical trial published recently, but most of the other literature is just single surgeon case series, some prospective and some retrospective. And that's not really the best type of evidence. The main advantage with GAT is that you don't need an expensive device to do it. It's you just need a suture. It costs about $10. So it's a relatively inexpensive technique, but technically it's much more difficult compared to, say, using a Hydrus or an iStent. On a whole, I would say these techniques are fairly similar in the benefit they give. So the average IOP you get after treatment is around about 14 millimeters of mercury, and we see on average about a 50% reduction in medication required. In terms of safety, I think one of the main problems is no response to treatment. So there is a subgroup of patients who don't have any pressure or medication reduction. I would estimate that to be around 15%. And then other things that can happen are high FEMA and something called peripheral anterior synechia, where the iris can get stuck in the stent or the angle and prevent it from working properly. Okay, so that's the transtrabecular MIGS. What about the subconjunctival MIGS? Well, there's really only one device that's in common use in Australia at the moment, and that's the PreserFlow. Now, it's questionable whether this is actually a MIGS, because it has some features that are more in keeping with trabeculectomy. So first of all, it's not an ab interno technique. You've actually got to go from the outside in, which means cutting into the conjunctiva. And it's a bleb-forming procedure, so you are exposing the eye to potential bleb-related complications that you get from trabeculectomy. But having said that, there are some advantages over trabeculectomy. So sorry, this is what the device looks like. It's made out of a biocompatible material called SIBS, S-I-B-S. It's quite flexible. It's basically just a tube with a lumen, and then it's got these little wings on the side which help anchor it in place. And the picture on the right shows one in position with the tip in the anterior chamber and the back end in the subconjunctival space. Can you play the next video, please, April? So this is a video just showing a pressure flow being inserted. So a little channel's been made through the sclera into the anterior chamber, and then the pressure flow is inserted through that channel until those wings are anchored in the sclera, like so. They're just pushing it in so it's anchored. Yeah. That just helps prevent the stent from moving around. And then some surgeons will tie it down so it's not sticking up in the air, and other surgeons will also put a suture down the centre of the stent just so they can control the flow early on and don't get pressures that are too low. And then once the position has been confirmed, then that conjunctival tissue is placed back over the top of the stent, and it's sewn back into place. And when it's working, you get aqueous flowing along the pressure flow and fluid flowing back over the back of the eye. Okay, back to the slide deck. Thanks, April. So the evidence in support of pressure flow is pretty good. There's some randomised clinical trials. Many of the studies compare it to trabeculectomy because that's the technique that it's most comparable to. And what we're seeing in Australia is that pressure flow is actually being used in preference to trabeculectomy now. So if you look at the numbers of trabeculectomy surgeries that were done in Australia prior to pressure flow becoming available, and what's happening now, that pressure flow is available, it seems to have taken over about 50% of those cases. In terms of the pressure reduction you achieve with a pressure flow, you sort of get the reported range is around about 11 to 15 millimeters of mercury as final resting pressure following the treatment, which is on average higher than what you get with trabeculectomy. But on the flip side, the reported rate of hypotony, so hypotony being pressure being too low, is lower with the pressure flow compared to trabeculectomy. And you get quite marked reductions in medications, so up to 75% of medications being withdrawn after the pressure flow has been used. And then that brings us to the final class of MIGS, that's suprachoroidal MIGS. And we do have one device currently available in this category. It's called MiniJect. Now, MiniJect is made of a material called STAR, which is basically this porous meshwork. It's highly flexible, and it facilitates the flow or percolation of fluid through it. The stent measures 5 millimeters long and about 1 millimeter wide, and it's inserted into the suprachoroidal space, and there's a diagram of one sitting in that space on the right there. Now, that space is a potential space. It doesn't exist in a normal eye, so it has to be created by the surgeon. And in fact, the whole concept of a suprachoroidal treatment such as MiniJect comes from observations that in eyes that have had an injury, which has caused a split in the suprachoroidal space, those eyes often end up with very low pressures. So it was thought, why don't we utilise that finding surgically to control pressure, and hence we've got the MiniJect. Now, could you show the MiniJect video? Thanks, April. Now, I don't have an actual surgery video of MiniJect, but I do have an animation which gives you an idea of what's done. So again, using a gonioscopy lens, the injector is pushed into the potential space between the choroid and the sclera. And then once the surgeon is happy with how it's sitting, the device is deployed because the retractor is withdrawn, leaving the MiniJect there. And you can see the animation showing how the aqueous flows through the MiniJect down and into the suprachoroidal space. Okay, back to the slide deck. Thanks, April. Now, Miniject, compared to the others, is fairly new on the block, so there's not a huge amount of research available on it yet. There are a number of single surgeon or group surgeon studies where patients have been prospectively enrolled and followed up to 2 years, but the numbers are very small. So certainly not the body of evidence that's available for some of the other devices. So far, the pressure reduction is fairly similar. So you're getting final pressures around 14 to 15 millimeters of mercury with 40% reduction in medication. And those numbers have been reported out to 2 years after surgery. Potential complications from this, one of the main early ones is bleeding. So when you create that split in the suprachoroidal tissue, it's quite prone to bleeding, and often straight away after surgery there's blood there. And again, there'll be a subgroup of patients in whom the pressure doesn't go down, and that may be because they develop scarring, which ultimately closes that space back up. I forgot to mention with the PreserFlow earlier about complications, and it is it potentially has similar complications to traditional trabeculectomy, so infection of the bleb, pressure too low, erosion of the device through the conjunctiva, that kind of thing. All right, so I just want to summarise what we've talked about this evening. So MIGS, minimally invasive glaucoma surgery, provides an alternative to conventional intraocular pressure lowering. And in fact, thinking back to that graph I showed you of risk versus reward, it really fills a treatment gap that existed when we were only using laser medication and conventional surgery. There's many MIGS options available, and they target different mechanisms of action. And one advantage of MIGS is that it has an improved safety profile compared to conventional surgery, and this is an important factor when deciding who's appropriate to undergo MIGS. So with that, I'll say thank you, and we'll open it up for questions.
Hi. Sorry,
Hello.
it looks like Tash has just jumped out. So hello, everyone. My name is April. I'm the comms manager here at Glaucoma Australia. I'll ask you the questions, Dr. Clement. Thank you for that. That was really wonderful. And so I'll move on to some questions. We do have quite a few that have come through. So
Okay.
I might select some, and then to our audience, anything that we haven't gotten to tonight, many of you have sent through emails, we will get back to you privately, our team, and we'll send those questions on to Dr. Clement as well. So first question, in aiming for the Holy Grail, so around 10, well, let me just pop this question up here on screen, Doctor. This might be better for you.
Yep.
For glaucoma patients, what would be the optimal number of stents to insert during a cataract surgery?
So I'm not sure what you mean by stents. If it's eye stent you're talking about, then there's diminishing returns with the number of stents you use. That's what the data suggests. So you get the biggest pressure reduction with one stent. If you add in two, you get a little bit more. And if you add a third, you get a little bit more again. There's not any data on using 4, 5 or 6 stents. But based on that trend, you would expect that adding more and more is not going to be particularly helpful. The thing that limits the amount of pressure reduction you get is episcleral venous pressure. So that's the pressure beyond Schlemm's canal. And that's why we don't see pressure reduction much below the 10 mark. And in fact, the average is around 14. So whilst you can achieve a pressure of 10 with the stents, it's uncommon. I would, based on our data, in everyone that gets 2 or 3 stents, the chance of getting a pressure of 10 or less is only about 10%.
Yeah, sure. And that kind of brings us to our next question anyway. So what is the average? And I suppose it's different patient to patient, but the average IOP reduction that could be expected?
It is different patient to patient. So the average pressure you achieve with treatment is around about 14. If you're aiming to get off medication, so for example, if you treated everyone and then took everyone off medication and just saw how they went without it, rather than tailoring the medication based on the pressure you want, then the average pressure gets around 17.
Right.
That's
quite significant.
Yeah, the size of pressure reduction you get is in part dependent on the starting pressure. So if you've got a high starting pressure, you're more likely to get a bigger reduction.
I see. We have another question here. So is it feasible to insert stents, such as the eye stent inject post-surgery? I'm assuming a larger surgery.
Yeah, you can definitely use the stents if you've previously had surgery before. So if you've had a cataract operation before, you can use the stents. If you've had a trabeculectomy before, which is no longer working, you can use the stents. If you've had a glaucoma drainage device before, you can use the stents. None of those things prevent you from doing it. The only thing that would prevent you from doing it is if you'd had some sort of procedure that removes the trabecular meshwork, because then the stents no longer have a structure in which to anchor. And that's the same for the hydrus, for example.
Right, we'll do 2 more questions if that's okay, and then we'll wrap up. So we've got a question from Erica here that's come through live on the chat. Will PreserFlow work with moderate to advanced glaucoma?
Yeah, so you can use PreserFlow in a whole spectrum of disease severity, so all the way from early through to advanced. If you've got narrow or closed angles, that is more of a problem, because in that scenario, what can happen is the PreserFlow ends up sitting very close to or touching the cornea. And over time, there's a risk that constant mechanical interaction with the cornea will result in the cornea failing. So it's at this stage, it's used preferentially in open angles.
Sure.
Yeah.
We'll just go question from Moira here, who has normal tension glaucoma, and she's had cataract surgery and has had a stent put into each eye. And 2 years on, optical nerve is still deteriorating. What should she consider next?
So that suggests that your average pressure control is not safe enough for your optic nerve, or there are other factors that are contributing to the nerve deterioration. So the first thing I would do is to try and get a better understanding, what is your eye pressure doing? So when you go into the clinic and have a measurement, that's just a snapshot in time, and that doesn't give you a true picture of the overall pressure control. Now, you may be having a higher pressures at 7 o'clock on a Friday night or 3 a.m. on a Sunday morning, and your doctor's not going to know about that because they never measure it then. So you can do a number of investigations to try and figure out what your 24-hour eye pressure control is like. And if it's high, then you can be more aggressive with the treatment to try and get that under control. And then the other thing to look at, if your pressure is truly low, but it's still progressing, is what other factors are contributing to the glaucoma progressing. And the sorts of things that you would need to look at is, first of all, blood pressure control, because believe it or not, low blood pressure is bad for glaucoma. And we tend to have our lowest blood pressures overnight when we're asleep. So again, it's something that goes unidentified. So if you do 24-hour blood pressure monitoring and find that the overnight blood pressure is low, you can make adjustments to try and bring that blood pressure up, and that'll help the glaucoma. The timing of your glaucoma drops can influence that. So some glaucoma drops, if you take them overnight, can drop the blood pressure. And there are other things such as sleep apnea, which potentially affect glaucoma progression as well. So there's quite a few things you can look at.
Thank you for that. It's very multifaceted, isn't it?
Hmm.
I will hand back over to Tash. Thank you for bearing with us through the technical difficulties, everyone. And thank you so much, Dr. Clement. I'll pop Tash back up here now and leave it to her to wrap up.
Clement,
Can't hear
for
you,
your
Tash. Oh, no, I can hear you now.
presentation.
Pleasure.
Can you hear me now? Oh,
Yes.
Thank you. I just wanted to say thank you very much for your wonderful presentation and showing our audience just exactly how, MIGS are performed. Not many people understand how that is done. So thank you very much. Yeah.
My pleasure. Thank you for having me.
That's okay. So in our conclusion, if we have any further questions, we are happy to answer them as they come through. So we will get to them in due course, and we will ask Dr. Clement to answer them if we are unable to. But just in our conclusion tonight to the presentation, again, we would like to thank Dr. Clement, and I would also like to take the opportunity to mention Glaucoma Australia's national patient support program called SiteWise, where we provide support to glaucoma patients and their families throughout their glaucoma journey by delivering information, education, and one-on-one emotional support. If you would like to speak to one of our 3 qualified orthoptist patient educators about your glaucoma, please feel free to contact 1-800-500-880. Thank you, Dr. Clement, again, and thank you for your wonderful presentation, and thank you all for joining us tonight. Thanks.
Thank you, Tash. Good night, everybody.
No problems. Good night.